Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. I hope that you've maybe listened to the first part this morning, or yesterday. Now you're listening to this second part, and you're going to smash through these questions and really reinforce that knowledge. If you've listened to that on your way to a night shift, and now you're coming home from a night shift in the car, I think you need to put some power metal on, like Dragon Force. Don't listen to this; you'll fall asleep in the car. But anyway, look after yourselves. We're going to get straight into it. How do local anaesthetic agents exert their clinical effects on nerve conduction? You're right. They work on the internal aspect of the sodium channel, this being a volt-gated sodium channel. But to do so, they must cross the membrane of this nerve, and to do so, they must be in their unionized form. They reionize inside that nerve, binding to these volt-gated sodium channels, and they have a use-dependent block, i.e. they prefer to bind to channels that are open, not closed. Why are some fibres more readily blocked than others? This is based on chiefly how myelinated these fibres are. Unmyelinated fibres are exceedingly susceptible to local anaesthetic agent, whereas heavily myelinated fibres are more resistant. As an example, motor nerves, very rapid in their conduction, very myelinated, take the longest period of time for a clinical effect to be observed compared to sensory or autonomic nerves. What type of drugs are local anaesthetics chemically? Now this is a bit of an awkward question, but they are amphipathic compounds. Remember, they have a lipophilic aromatic ring on one end and a hydrophilic amine group on the other end. They are linked with either an ester or an amide linkage. How are local anaesthetic agents classified? Remember, this is a classify or die question, folks. And then also, please give me some examples of local anaesthetic agents in these classifications. So remember, it's amide and ester are the two classes of local anaesthetic agents, although ketamine also has some local anaesthetic effect, but let's not go there. And then naming some agents: amide agents, bupivacaine, levobupivacaine, ropivacaine, lidocaine, prilocaine. Ester agents: cocaine, 2-chloroprocaine, and then procaine if you're looking for a third one. How are these local anaesthetic agents metabolized? Remember, we're back to our classification here, guys. So you'd say amide anaesthetic agents are broken down in the liver by N-dealkylation, whereas ester agents are broken down by plasma and tissue esterases because they are ester-based agents. Esters break down more quickly than amide agents, but note that ester agents have a breakdown product called para-amino benzoic acid, PABA, which has a proclivity for causing allergic reactions and irritation. What factors determine the onset time of a local anaesthetic agent? So classically, the lipophilicity of the agent, dictated by the benzene rings. This is fairly consistent across a number of molecules. More importantly is the pKa of the molecule. pKa of a molecule being the pH at which the drug is 50% unionized. However, we're more interested in the unionized fraction at physiological pH, noting that the greater the unionized fraction, the faster the onset. What factors determine the duration of action of a local anaesthetic agent? So the protein binding of the local anaesthetic has a significant impact. The higher the protein binding, the more prolonged the onset. But also, it's important to think about the vascularity of the space. Highly vascular spaces clear agent quicker, and whether or not you've introduced additives to that agent, such as adrenaline or clonidine, that might cause local vasoconstriction or work synergistically with that agent to prolong the effect. Compare and contrast lidocaine and bupivacaine. Both of these agents are amide anaesthetics. The onset times differ. Lidocaine has a faster onset time than bupivacaine. Offset times. Lidocaine offsets faster than bupivacaine, although this can be modified by the addition of adrenaline. Pharmacokinetically, lidocaine has a greater unionized fraction at 25% because of its pKa of 7.7, whereas bupivacaine is 15% unionized with a pKa of 8.1, and this dictates the onset times I've just mentioned. The maximum safe dose of lidocaine is 3 mg per kilo or 7 mg per kilo with the addition of adrenaline, whereas bupivacaine safe dose is 2 mg per kilo. Bupivacaine is more cardiotoxic than lidocaine. How does levobupivacaine differ from bupivacaine though, Doctor? Bupivacaine is a racemic mixture of R and S enantiomers, whereas levobupivacaine is just the S enantiomer. The chief reason for doing this is that there is markedly reduced cardiotoxicity of levobupivacaine versus bupivacaine. You tend to see CNS toxicity effects of levobupivacaine before cardiovascular effects, giving you a greater opportunity and window to alter the clinical outcome of a toxicity event. Interestingly, at lower concentrations, it tends to produce more of a sensory than motor blockade. Describe the properties of prilocaine, Doctor. Prilocaine is another amide local anaesthetic agent. It has a pKa of 7.7 to 7.9 and is a third unionized, so it has excellent onset characteristics when used intrathecally. It is less protein bound than bupivacaine at 95% and lidocaine at 64 to 70%. Prilocaine's protein binding is 55%. Therefore, its duration is shorter, but it may mean that there's a greater free fraction of molecule at injection site. It's also found within Emla cream and historically had been used for Beers blocks. In high doses, it can cause a methemoglobinemia due to a metabolic byproduct of its hepatic clearance. Why might a local anaesthetic agent fail to achieve surgical field anaesthesia in an infected site? This is chiefly an issue to do with the pharmacokinetic property of these agents, the pKa. Infected tissues are more acidic. This leads to a smaller unionized fraction of local anaesthetic agent available to cross nerve membranes and exert effect when injected into sites of a more acidic pH environment, i.e. infected. Equally, duration of action may actually be shortened if the site is hyperemic, courtesy of the inflammatory process. How might you go about improving the onset time of local anaesthetic agents? This is primarily achieved with the addition of sodium bicarbonate to raise the pH of the solution. However, more importantly, it will raise the pH of the tissues the local anaesthetic agent is introduced into, increasing the unionized fraction, leading to faster onset times as more agent crosses into neuronal cytoplasm. This is chiefly done with lidocaine. Bicarb is not optimally compatible with bupivacaine and levobupivacaine. What is Emla cream and what is it used for? Emla stands for eutectic mixture of local anaesthetics, being composed of 2.5% lidocaine, 2.5% prilocaine. Onset time 1 to 2 hours, lasting for up to 5 hours if it remains on the skin long enough to exert its full effect. Its use is topical anaesthesia for procedures, classically in paediatric practice for cannulation. They might ask you to define what a eutectic mixture is, and a eutectic system or mixture is a homogeneous mixture that has a melting point lower than those of the constituents. In the case of local anaesthetics, these agents would be considered solid at room temperature but become an oily preparation when mixed. In this case, you find them as a emulsion of oil and water. What are some maximum safe doses of common local anaesthetic agents? Lidocaine 3 mg per kilo, 7 mg per kilo with adrenaline. Bupivacaine and levobupivacaine 2 mg per kilo. Ropivacaine 3 mg per kilo. Prilocaine 6. No one's going to ask you about cocaine, and if they do, shame on them. What factors influence local anaesthetic systemic toxicity? And you probably could be quite clever and break this down into like patient factors, environmental factors, and anaesthetic factors. Patient factors would be their cardiac output, their hepatic function, their renal function, their body mass. Surgical factors, site of surgery, and therefore what you're trying to block, if it's a high absorption versus a low absorption tissue. And then anaesthetic factors, I'd think about these in terms of human factors, so not doing a stop before you block, patient being covered up prior to administering block, not having a mark on the patient, patients being poorly informed, performing more than one block increases your risk of error, and not using ultrasound increases the odds of toxicity by 4 times. Please rank the injection sites in terms of most to least systemic absorption rate. Whatever acronym you use here, guys, remember that it starts with intercostal, and then caudal, and then epidural, then brachial plexus, and then subcutaneous. What are the systemic effects of local anaesthetic systemic toxicity? You should be able to say, I break this down into central nervous system effects and cardiovascular system effects. Both seem to have a early and late stage. Stage 1 CNS, sensory disturbance such as tinnitus, circumoral tingling, pressure in the ears, metallic taste in mouth, or other altered sensorium, leading to seizures, agitation, respiratory depression and coma, whereas cardiovascularly, you may see a brief hypertension before finding a hypotensive state with poor inotropy and deranged cardiac conduction leading to an assortment of arrhythmias, VT, VF, asystole bradycardia. What precautions can you apply to reduce the odds of toxicity when administering a regional nerve block? Calculate the right dose. Choose an appropriate drug, levobupivacaine being safer than bupivacaine. Aspirate before you inject. Use incremental dosing. And remember that ultrasound reduces your chances of problems 4 times over. What are the advantages of prilocaine over bupivacaine for day case spinal anesthesia? Prilocaine's prompt offset improves the chances of same-day discharge for patients having day case surgery, noting that the motor block recovers after 158 minutes instead of 220 minutes. Just remember, folks, when you're using prilocaine, it does fix pretty quick, so make sure you're pretty rapid in lying that patient down, tipping them where you want them to be, or keeping them sat up if you're aiming for that saddle block. Okay, that is probably enough question fun times for you guys. I don't want to stretch it out too long. You need to have an excellent weekend. There are going to be some more questions on the show notes for the episode if you're really loving life, or if you want to quiz your mates when you're doing some practice. Anyway, thank you very much. Have a great weekend. Hope you're enjoying the show. Cheerio and goodbye. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.